Hi, my name is Dr. Claire Touchy. I'm the Chief Medical Education Officer for the Medical Council of Canada and an associate professor at the University of Ottawa in the Department of Medicine. On behalf of the Medical Council of Canada, welcome to today's session titled The New MCC Qualifying Part 2, What's in it for me? This webinar is intended for candidates who will be doing the examination in the fall of 2018 and beyond. If you are doing the examination in May of 2018, this webinar is not for you and you should therefore sign off. I'll begin with a presentation that will last between 20 and 25 minutes, and then we will go on to a question and answer period of approximately 20 minutes and finish at 8:45. We invite your questions during the question and answer session that will follow my presentation. To submit a question, please go to the question mark symbol on your screen. Simply click on this, write your question in the space above, and then click Submit. The question will then be repeated out loud so that everyone has the benefit of hearing the question before I respond. So without further ado, let's start the presentation. So for presentation overview, we'll talk about the Medical Council of Canada. Why do we exist? Why do I need the LMCC? Why is the exam changing? What is the new examination blueprint? What are the components and content weightings? I have concerns about taking a new exam. What does that mean for me? Exam preparation and tools. And we'll finally speak about pass-fail decisions and the reporting of scores. And then we will go on to a question and answer session. So the Medical Council of Canada was founded in 1918. And the reason why this organization exists is that it was born out of the rationale of concerns for patient safety and developing a credential to enable physician mobility. This allowed physicians to cross over borders from province to province, and their LMCC was transportable across those borders. It is thus a national qualification in medicine that would be acceptable to all provinces. So why do I need the LMCC? Well, the licentiate of the Medical Council of Canada, or the LMCC, is divided into three parts. The Mc Cqe Part 1, which is the computer-based examination of knowledge and application of knowledge, which many of you would have taken in the past. The MCC Qe Part 2 is the Objective Structured Clinical Examination, or the OSCE, and that will be the focus of tonight's webinar. To become a licentiate, you also need 12 months of postgraduate clinical medical training deemed acceptable by the executive director. Your LMCC is actually a necessary component for licensure in Canada. So why is the exam changing? So an exam should always reflect what is required of physician for safe and effective patient care. And to do so, every few years, you have to make sure that your examination program reflects medical practice. In 2013, the MCC conducted an extensive practice analysis exercise. The conclusion of 4 areas of research and 12 subject matter experts led to what is known as the new examination blueprint of the Medical Council of Canada. What is this new examination blueprint? Well, the examination blueprint is very much like a blueprint used in architecture. It is a blueprint that helps us define our exams. It defines the content that's going to appear on the exam, and it defines how we are going to, how we set our exams up. The new blueprint is divided into the dimensions of care and physician activities. Dimensions of care have 4 areas: health promotion and illness prevention, acute care, chronic care, and psychosocial aspects of care. Physician activities is also divided into 4 areas of assessment, diagnosis, management, communication, and professional behavior. This blueprint is the same blueprint for both our Part 1 and Part 2, and we will discuss in a few slides the actual test specifications for Part 2. What is the purpose of the MCC Qe Part 2? Well, it assesses the candidate's core ability to apply medical knowledge, demonstrate clinical skills, develop investigational and therapeutic clinical plans, as well as demonstrate professional behaviors and attitudes at a level expected of a physician in independent practice in Canada. I'm going to emphasize the word core abilities, as this is the main focus of our exams. We are examining core competencies expected of all physicians, regardless of the area of specialty training. So what will be the content weighting of the MCC Qe Part 2? So this is what the test specifications of the exam will look like. It will be divided into the dimensions of care, with 20% of the exam focusing on health promotion and illness prevention, approximately 35% on acute care, 25% on chronic care, and 20% on psychosocial aspects of care. Physician activities will be divided approximately equally amongst the 4 categories, approximately 25% each for assessment diagnosis, management, communication, and professional behavior. And this is how the exam will be set up. How will the examination be structured? The exam will continue to be a 2-day exam. On day 1, there will be a total of 8 stations. 7 stations will be a 14-minute duration, which is something new for our examinations. In the past, the long stations were 10 minutes each, and we have gone to 14 minutes to allow us to emulate a physician-patient encounter in most clinical settings. Of the 8 stations, there will be 1 pilot station, which will not count towards your score. On day 2, we will have paired stations. There will be a total of 4 paired stations, 3 paired stations that will count, and 1 paired station that will be a pilot, which will not go towards your score. The paired stations will be 6 minutes each, with 2 minutes in between. The first paired station can be a patient encounter, or it can be a station where you will be asked to review a chart or review an article prior to seeing a patient in the second 6-minute encounter. The second encounter could also be an encounter where you have a discussion with an examiner or have to speak to another individual. What will I be required to perform? So there are several things that you might be required to do in a station. You might be asked to elicit a history. You might be asked to conduct a focused physical examination, or to do both of these, thus elicit a history and perform a focused physical examination as a combined task. You may be asked to manage or resolve a patient problem, to assess and manage an urgent or emergent situation, to counsel a patient and or family members. You may be asked to answer oral or written questions, and those written questions would come in the form of short answer write-in or extended match multiple choice. You may be asked to summarize and present findings to an examiner or simulated colleague. You may be asked to read or reference material pertaining to the patient's situation, such as articles, charts, test results, medication lists, or summaries. And you may be asked to interact with physicians or other healthcare professionals. So I'm concerned about taking a new exam. So I want to reassure you that all our stations have been pre-tested. That means that the new stations have been piloted and have been shown to be appropriate for this exam. So these have been piloted on prior examinations and are deemed to be acceptable for the level of candidates in this examination. The stations that are actually being piloted on the new exam will not count towards your total score. So let's talk about an example of a station. So this station, on the door will be written, Angela White, 19 years old, comes to the walk-in clinic for reevaluation of a post-appendectomy wound infection. Her vital signs are as follows: blood pressure of 130/64, heart rate of 72 per minute, respiratory rate of 16 per minute, temperature of 36.7 degrees Celsius. And your task is in the next 14 minutes, assess and initiate management of the patient. When you enter the room, there is a young woman who is obviously not looking at you and is not easy to enter in conversation. But you find out that she has taken her antibiotics, has completed them, and her wound infection appears to be resolving as normal. But upon questioning, you realize that she is not easy to talk to and is quite obviously having issues of mental health. So thus, the objectives of the stations are based on the following 3 CanMEDS roles. In the expert role, the clinical situation is one of suicidal behavior, and you must be able to determine this. The communicator role is to tailor the interview to the clinical context, as well as establish a common understanding and negotiate agreement concerning diagnosis, management, and follow-up. In the professional role, you are to know and demonstrate the professional behaviors to ensure patient safety. So you can see from these that we are not only looking at determining the medical expert role, but also looking at other roles throughout the exam. What are we assessing in this station? This is what the checklist looks like. Checklist looks at 4 main areas: that you clarified that the infection has resolved, that you have explored the possibility of a mental health disorder, that you are proceeding to suicidal risk assessment and that you proceed through the suicidal risk assessment, and that you initiate management of safety risk. All of these must be done completely satisfactorily and not attempted only. In addition, we also have rating scales. These rating scales will assess you on patient-centered approach of history taking, physical examination, on patient-centered approach to treatment planning, on your organization of the encounter, and on interpersonal behavior. So as you can see, we do not only assess your ability to make a diagnosis on this person and to be able to manage safely, but also on organization and interpersonal behavior. Examples such as this one will be available on our website soon, as of July 2018. We will have 3 full examples of stations available for you. These stations were actually developed by our OSCE test committee, were piloted on exams in the past, but were taken out of our examination schedule specifically to be put on the website for your preparation as preparation resources. How should I prepare for the exam? Part 2 is based on common or critical patient presentations and colleagues or other healthcare professional family member encounters related to our objectives, which can be found on mcc.ca. You should therefore use these presentations from our objectives and consider organizing your studies similarly rather than studying by disease or body system. For each of these patient presentations, identify key diagnoses as well as the critical information needed for a diagnosis and to rule out the differential diagnoses and for treatment. This will help you in set up your studies and in imagining what kind of OSCE stations we could be asking you. For the interpersonal interaction, please review the intrinsic roles of the objectives and make yourself familiar as to the expectations. For example, the communicator role, collaborator role, professional role, etc. How else can I prepare for the exam? As of July 2018, we will have an OSCE orientation on our mcc.ca website. It will include everything you have ever wanted to know about OSCEs and probably more. Please make sure that you check that out as of July. How do I keep up with upcoming new tools? We have 2 websites that are available to you. The MCC Assessment Evolution website has information about the changes that are occurring to our examinations, as well as explanation on the new blueprint, more than what I would have discussed today. And this can be seen on mccevolution.ca. Remember that our MCC objectives are presently available on mcc.ca, and examples of the OSCE stations will be available in July. Now let's move on to pass-fail decisions and reporting of scores. How do we decide the pass score? We do so through a process called standard setting, which is done with a group of clinicians. This group sets a standard that is criterion-based and not norm-referenced, which means that there is no predetermined percentage of failure. The cut score is set, and anybody that meets that cut score will pass the exam, which means that theoretically 100% of candidates could pass the exam if they so meet that criterion. Now, the standard setting exercise in the fall will be done after the fact to actually use real examination data in the process of the standard exercise so that we understand the consequences of the score that we will set. Can this new exam fail a large percentage of candidates? By using the very strict criteria of a standard setting exercise, this would be very unlikely. It is most likely that the standard will be set in and around the same as it has been in the past. The reporting of the scores. When will you know your score? Scores will be available in January 2019 for the fall session of 2018. The scores are not reported as a percentage score. They are represented through a total score with a scale of 50 to 250. You will also receive a final result of a pass or a fail. In addition, you will receive a supplemental information report, which is based on the blueprint domains as we have discussed earlier, and not on the disciplines as in the past. How do I stay informed? You can stay informed, as discussed earlier, on the MCC Assessment Evolution website through mccevolution.ca. You can also get your MCC objectives at mcc.ca, an example of OSCE stations. MCC Assessment Evolution monthly e-bulletins are available, and you can subscribe in the following links at mccevolution.ca/resources/news. FAQs and videos will also be available on mccevolution.ca. On behalf of the MCC, all the best in your preparation for the exam. If you have any questions, please visit us at mcc.ca or do not hesitate to contact us through communications.mcc.ca. I now invite you to ask questions. To submit a question, please go to the question mark symbol on your screen. Simply click on this, write your question in the space above, and then click Submit. The question will be repeated so that everyone has the benefit of hearing the question before I respond. If you did not hear your question asked, please know that we will respond. Please send your question to communications@mcc.ca after this webinar or at any time. We are here to assist. I will now take your questions.
Okay, our first question is this evening is why does this webinar only apply to the fall 2018 session and not to the spring session of this year?
Can you repeat the question, please?
Absolutely. So why does this webinar only apply to the fall 2018 session and not to the spring 2018 session?
Okay, thank you. The spring 2018 is still following our old blueprint, and the new blueprint is taking effect only in the fall of 2018, and thus it's going to be our new exam. Just wanted to let you know that if you are in full screen mode and do not see your question mark symbol, please exit the full screen mode, and that will allow you to ask questions.
Okay, our second question this evening is what are MCC's expectations in terms of history-taking stations and how candidates should perform in them?
The history-taking station will depend, but you may be asked to take a history of a clinical component. You may be asked to take a history regarding a patient who is about to be discharged. Or you may be asked to elicit more information about a clinical situation that you've had a chance to review the charts. So you may be asked to review, for example, a post-op patient who had a severe allergic reaction and they are now returning to clinic, and you will want to clarify this. Those are basic examples.
Okay, a question here for those who are not currently in a residency program. Does taking the Part 2 help to guarantee your acceptance to residency programs?
So the Part 2 exam is not necessary to enter residency in Canada. It is in fact taken during residency in Canada. But for international medical graduates, the best way to find out if your Part 2 is helpful in applying to a residency spot would be to speak to the particular program that you are applying to.
So is it possible to take the exam again even if one has already passed it?
If you have already passed the Part 2, you are not allowed to take it again. It is truly a pass-fail exam. We do provide WIT scores, but the most important thing from a licensure perspective is to pass the exam.
Are there any changes to the eligibility or application criteria?
From the eligibility criteria, there are no changes from what we are doing presently. Candidates in Canada who are in their first year of residency are allowed to apply to be eligible by the end of their first year of residency.
So another question, if I fail the fall 2018 exam, will I be able to retake it the next available session?
Yes. You will be able to take, so if you fail the fall 2018, you will be able to reapply for the spring of 2018. You are allowed 4 attempts to this examination as of January of 2018, and thus would be able to take 3 attempts consecutively, and if you should fail 3 attempts, you would then have to wait 1 more year to take your 4th attempt.
Okay, another question here. Are we required to remember specific doses for certain medications?
It would be unusual to be asked for specific doses of medications, as that's not what happens in reality. I would say that if it is an emergent situation, you should know your doses for emergency cases, as that might need to be specified.
Question here about lab values. Will laboratory values be given in both Canadian standard and US standard units, or will normal reference ranges be given?
So for lab values, they will be given in international standards and not in American standards. But usually if it is a written question where you need to answer an extended match, for example, you will get the normal values given to you. And I would have to ask whether or not in an emergency station or in a specific station where it is verbally interpreted, whether or not normals would be available.
One question came in about whether tonight's presentation slides will be available.
So tonight's slides will be available on mccevolution.ca as of tomorrow and will be archived for the foreseeable future.
Question here about exam eligibility. Will there be any limitations regarding the number of times a person can attempt the exam?
The examination can only be attempted 4 times. As stated previously, you can do it 3 times consecutively, and if failed on the 3rd attempt, then the 4th attempt can be taken after a year. Only in exceptional circumstances can a 5th attempt be made.
Question here about exam capacity. Is there any change in your capacity for numbers of candidates to sit this examination?
The exam presently is what we call capped, so that we have limitation to the number of candidates who can take it in each session. We would encourage you to pre-register for the examination so that you can make it to the examination of your choice. However, should you not make it to that specific examination, you would then qualify for the next examination session.
Question here about guidelines. So if one takes the spring exam or the fall exam, certain guidelines have been updated, and are candidates expected to follow the latest guidelines, and if not, what's the cutoff?
So examinations are, like I said earlier, are really based on core competencies. So it would be unusual for us to ask you specifically to adhere to strict guidelines. However, for diseases like diabetes or myocardial infarction, you may be asked about general guidelines to follow in follow-up. But I would say that if a guideline has been changed between within a period of 1 year, this would probably not be part of the questions on your examination.
Okay, question here about OSCE reference books. Is there any OSCE reference books acceptable to MCC? And is there any examiner checklist for different tasks available online as examples?
So we will have 3 examples of different checklists that we use. So for 3 different stations, the type of not only checklist, but also the types of global rating scales that we use will be available as of July 2018 to help you out from that perspective. As far as books to help you out, I would not be able to give you a specific reference for this.
Okay, question here about pre-registration for the fall 2018 exam. When can we pre-register for that exam?
So pre-registration for the fall 2018 examination will open at the end of April 2018, but you are able to sign up for a notification of that exact date, and you can do that as of tonight on mcc.ca under the MCC Qe Part 2 section of our website.
Question here about the exam fee, and will it change?
The exam fee is set by our council members, and it is usually set at least a year in advance. Exam fees can only go up by a certain percentage every year, and thus will not make a big jump. And those fees should be available online, and if they are not yet, they should be available very soon.
Question here again about eligibility. Are candidates allowed to take this new exam if they've already failed the old Part 2 multiple times? Absolutely.
So if you have failed the old Part 2 multiple times, as of January 2018, our new rules of only being able to take the exam 4 times come into play. but you would start with a clean slate as of January 2018. So you would still have 4 attempts to the exam.
Question here about what happens if one wants to take the exam for a 5th attempt. What are the exceptions that would allow for that 5th attempt?
The exception for the 5th attempt are left at the discretion of the executive director, and therefore would escalate to the executive director for an answer.
So a question about asking standardized patients questions. Can we ask multiple questions at once, or will the standardized patient only answer one question at a time?
So you must treat the standardized patient as you would any real patient. So you should ask the questions the same way you would. So target shooting or trying to ask as many questions as possible is not the way we usually deal with patients, and would not be the way that we expect you to interact with the patient in this exam.
One question here. Please give some type of examples of cases of what is expected in acute-based scenarios.
Can you repeat that question, please?
The person is looking for examples of cases for acute-based scenarios.
Acute
scenarios.
Scenarios? So acute scenarios. So think of things that would occur in an emergency room, or even better, think of things that would occur on an airplane. So what would be expected of you to be called in an airplane? So think of things like syncope or acute chest pain would be 2 of the common ones that you would be expected to manage.
A question here about the results, a release date. So as results will be published in January 2019, will the timeline to share documents in CARMS change too?
For your application for residency, Part 2 is not necessary for CARMS application. If you're applying for a fellowship, these dates will be, so for a subspecialty such as in pediatrics or internal medicine, these dates will be adjusted for a CARMS application.
So a question about standard setting process. Because it's happening after the exam, what happens if a large proportion of candidates are slated to fail?
So the reason why we're running the standard setting exercise after the fact is to try and mitigate that as much as possible. So we are planning to use actual examination data, your examination data, to do the standard setting exercise and to look at consequences. The standard setting exercise does need to fit certain norms, and having an extremely large number of candidates failing would be deemed unacceptable, and thus the exercise would start over again.
Will psychosocial aspects be assessed in each station or case, or is it only attributed to some cases only?
So each of the domains of the blueprint will only be assessed in certain stations. None of the stations will have, not all the stations will have psychosocial aspect, just like not all stations will have aspects of health promotion and illness prevention, for example. But the same holds true for physician activities. Not all stations will have all 4 components of physician activities. Some will focus on assessment diagnosis, some will focus a little bit more on management, and some might focus solely on professional behaviors.
Question here about the difference between the types of exam stations on the 2 days of the exam.
The day 1 of the exam will have 14-minute stations, which will mean that you may be asked to do multiple tasks. So this is one where you may be asked to deal with an emergent patient, where you will need to do assessment, pose a diagnosis, pose a management plan, communicate, and act professionally. On the day 2 of the exam, which are paired stations, where you have 6 minutes in the first part of the station, where you might be asked to review a chart, review some diagnostic tests, review some x-rays before you then go into the encounter with the patient, which will last 6 minutes. The counter to that is that you may start with the patient encounter and then come out and have to discuss your diagnosis and management with an examiner.
Question here about what happens if one fails. Would a fail on any MCC exams be reflected on the LMCC certificate or be available to residency programs even after passing the exam?
So if you fail the exam, that does not get registered for the licentiate. To acquire your licentiate, you must pass both aspects of the exam, and only then would you get your licentiate to move on to licensure.
Is the core of the new exam prevention and promotion?
No, as mentioned in the blueprint, approximately 25% of the examination will focus on illness prevention and health promotion. So part of the exam will also be on acute care, on chronic care, and psychosocial aspects of care.
A question here on the evaluation. So does the patient also evaluate candidates, or is it only the examiner?
At this point in time, only the examiner is assessing the candidate.
So a question on the standard setting process. What's an acceptable failure rate in a standard setting exercise?
That is set up by norms, which the Committee of Subject Matter Expert will set up before the fact. There is an exercise that they will do to set up minimum and maximum failure rates before they take on the exercise. So I can't tell you a priori what those will be. But remember that those subject matter experts come from our schools and from our medical environment. So they are used to working with young physicians who are about to go into independent practice and know the definition of what we're looking for.
Okay, so when entering a station, is it better to shake hands with the patient or not? If yes, should we wash our hands?
What I can tell you is that these stations are meant to be simulation of what it would be like to have a patient encounter. So it depends on, some of it depends on your personal style. Certainly there will be hand wash available in each of the stations, and if you're most comfortable with shaking the patient's hand, then please do so.
What is the recommendation for reviewing contraindications for certain medications?
Can you repeat that question, please?
What is the recommendation for reviewing contraindications for certain medications, as there are usually numerous contraindications that may not be completely covered? And what is the recommendation in an acute scenario?
So if you are discussing with a patient any medications, you should, or if you are discussing with a healthcare worker on medications, you should be able to discuss and be able to review or assess whether or not the patient has any of the major contraindications, and you should be able to discuss indications and contraindications with the patient or with the healthcare worker, depending on which is appropriate.
Question about the exam being offered in various centers. Is it possible that new centers are going to be added?
Presently, we have 18 different centers, which will be the ones that will be available in the fall of 2018.
Just a question to review again, any tips for people who are about to start their studies for the new Part 2?
So tips would be to go to the objectives, look at our clinical presentation, look at what is common and what would be deemed core competencies for all graduating physicians, regardless of their specialty. I would use that as a basis to start thinking about what is it about that I need to know about health promotion, illness prevention in these settings, what are the acute areas, what are the chronic areas, and which are the psychosocial aspect areas of those cases. How would I assess, diagnose, how would I manage, how would I communicate with people in those circumstances, And for professional behaviors, I would certainly look to the other roles in our CanMeds on our website and look at the objectives specific to those roles so that you know what the expectations are and what could be asked of you on stations.
A question here about the difference between the new Part 2 exam and the NAC examination.
The NAC examination, which is the National Assessment Collaboration Examination, is an exam for international medical graduates who are about to enter residency. So it's really set at the level of a graduating medical student in Canada versus the Part 2, which is an exam that's one step up. It is an exam that is designed to test the clinical abilities of a physician about to enter independent practice. Although in Canada you still need certification, the core competencies that we are testing are at the level of independent practice.
So questions here about how the Part 2 fits in the broader process for those who are trying to integrate into the Canadian medical system.
I'm not quite sure what the question is, Jessica.
How does the Part 2 fit in the process for someone who's looking to get a license to practice medicine in one of the provinces or territories?
So if you're looking to get a license to practice medicine in Canada, as stated earlier in the talk, there are 3 elements that you need. You need your Part 1, you need your Part 2, and you need 12 months of postgraduate training in order to obtain your full license as one of the aspects of your full license in Canada. In order to obtain your full license, you also have to have an MD degree from an acceptable medical school and have certification in Canada with one of our 2 colleges, so either the College of Physicians and Surgeons of Canada or the College of Family Physicians of Canada.
Question here around eligibility. So one of the eligibility criteria to take the Part 2 is to have 12 months of postgraduate training. Does residency count as eligible postgraduate training for the Part 2?
Absolutely. That is what we mean by postgraduate training. It is residency training.
We're trying to get to as many questions as possible. When a patient asks for drug list side effects, how many side effects should be mentioned for each drug?
Obviously, we're not going to ask you to list all of them. You should list the most important and the one that have the most ramification, just as you would with a patient that you're seeing in real life.
So question, do you think that the new exam will be overall more challenging than the previous one?
The exam will have a certain different focus. There's going to be a slightly more emphasis on core abilities. We're trying to get away from some of the detailed work that is more specialty specific, and we are hoping to concentrate our efforts on the various CanMed roles, including communicator, collaborator, and professional. Thus, the exam will probably be more familiar for Canadian residents in that I suspect that it is more what you do on a day-to-day basis as residents in practice, and hope that it is more representative of the work that you do.
Okay, I think we're at our final question. So why is the standard for the exam set as physicians about to enter independent practice when the examinees are often residents early in their career?
That's an excellent question. It's because we're looking at the core competencies of those skills. So we're looking at general core skills, but we do take our standard setters, our subject matter expert do take into consideration that you are at that point in your training, and that those would be the ones that would be acceptable for those roles by our regulators as being ready to enter independent practice. So without further ado, I would like to thank you and wish you the best of luck.